So, good afternoon, everyone. Thank you for joining us. We're excited to welcome Harrison Newman, Vice President of Benefit Consulting here at Corporate Synergies. Today, Harrison will be moderating our panel discussion as our industry experts will discuss the benefit trends in driving plan renewal decisions. If you have any questions, you can submit them in the chat, and we'll try to address questions about halfway through and then again at the end of the session. And you can always email us if we don't get to your question today. Also, the recording will be sent within the next day or two, along with the SHRM and HRCI credits for those who are eligible. So with that, Harrison, I will turn it over to you to introduce and give a little intro.
Thanks, Brianna. Thank you, everyone, for joining us. 2026 was one of the toughest renewal seasons many of us have seen. 20 and 30% renewals were common, even without catastrophic claims, for many different reasons. I'm joined here today by three of our top industry leaders to discuss what we're seeing and what we're discussing with our clients for 2027. We're going to focus on steerage and navigation, J-code drug management, as well as GLP-1 strategies. With me today, we have John Crable. John is a senior vice president based out of our Metro Philly region. John brings 30 plus years of industry experience to his clients. John's expertise is empowering, innovating strategies that manage cost and reduce risk while enhancing the member experience. Eric Brewer is a vice president and senior benefits consultant based out of our Florida region. Eric has been in the industry for 17 years, with the last 13 at CSG. He enjoys helping his clients win with innovative concepts that help challenge the status quo in the challenging healthcare marketplace. And representing the West Coast, we have Paige Hallett. Paige is a strategic benefits consultant and former CSG client with 2 decades of human resource and total rewards expertise. At Corporate Synergies, she partners with employees to design health and welfare plans that drive cost efficiency, strengthen well-being, and support enterprise objectives guided by strong client-focused mindset. Thank you all for joining us today, and I'm excited to have this conversation. To kick things off, for those of us, so we're going to start off the conversation talking about steerage products. For those who are less familiar, how would you define steerage or navigation in today's benefit world? How does it work, and what does it do for the employees? Paige, you want to take this one to start us off?
Sure. Thanks, Harrison. So I think historically we used to think about steerage in terms of just simply guiding members to the right care at the right time and in the right setting. But now in the current benefits environment, we're seeing steerage in a much more kind of targeted fashion. So we're looking at steering members toward high performing providers. And what does that mean? It means not just, steering members toward doctors who have, high reviews on Yelp or Health Grades or Google, but actually doctors that have better outcomes, perhaps that have more conservative treatment approaches or lower rates of infection. And there are ways to accomplish that through incentivizing members through plan design to steer members toward these higher performing doctors. And I think that's kind of what steerage looks like in the current landscape.
So why do these work? What's actually driving the savings? John, you want to take that one?
Sure. So as Paige had mentioned, it's the efficiency of the providers. It's reducing readmissions, reducing infection rates, things along those lines. And really one of the reasons it works is we're finally empowering patients with information and knowledge that allows them to help find the appropriate provider or facility. We've been asking members and patients to do this for years, but really not arming them with the information to allow them to make informed decisions.
So it's basically it's changing around what we've done for years. For years, we've tried getting the broadest networks. We've tried getting the largest network, the most doctors. Now we're seeing that shift to this quality-driven network. Eric, how are you seeing that shift work? Why are you seeing that shift be successful?
Yeah, I mean, I think, Harrison, I appreciate the question. I think for the last 15, 20 years since I've been in this business, I mean, I think the objective for most employers that we work with is, broader is better, right? How do we continue to give our employees as many choices as we can from a plan design perspective? I think what we're seeing in the market, and we saw this in the last really couple renewal cycles, is the ability to achieve discounts from a provider perspective is kind of plateaued. So employers are left with really no other option other than, how do we look at other ways to steer people appropriately? I think I would say the simple description of it is right care, right setting, right time. How do we get people to achieve or to get the right type of procedure at the right facility or hospital system? And are we sure that it is appropriate based on the condition that someone has diagnosed? So those are, I think, important elements of really the why behind this. I think secondarily, it's the branding is important, right? I think Paige said it well. We can't, and I don't think it's appropriate to brand this as simply low cost. I think it's more so a steerage towards high performance networks, which isn't always lowest cost, but it's just making sure we're getting the most out of our benefit spend and we're lowering readmission rate and things of that nature.
So I love that, Eric. And I think that's key because when most people take the average employee, when they think, hey, you're steering me towards a doctor, they're thinking a low cost doctor. They're thinking you're getting a kidney transplant in a back alley somewhere, exaggerating a little bit, but you know what I'm talking about. But that's not the case right now. We're seeing that even if it's a more expensive procedure, if it's a doctor with less complications, the overall cost is going to be better off. But a lot of that goes into messaging. So, Paige, I'll give you this question. How do you message this to the employees? I know communication is going to be key, but how do you get the employees to buy in that we're doing this to help them and find the best care and not do this to find the back alley kidney transplant?
Good question, Harrison. And I think there's a couple components. There are vendors, partners, carriers out there that will help offer and package this type of solution and steerage. So there is a requirement to do a lot of education around it to get members adopting like a navigational tool, for example. But you can incentivize those members by not just educating them that they have access to higher performing doctors, but through plan design, incentivizing them to engage because you can either waive or reduce member cost sharing. You can layer on an HSA or an HRA to where they're incentivized to seek out these higher performing doctors just by virtue of spending less. They know that they're going to spend less from a member cost sharing standpoint. So I think that alone gets members' attention. But back to kind of the what goes into the provider rankings and what is the data that drives these high performing doctors? Well, a lot of the partners out there, at least some of them, have access to hundreds of millions of patient claim data. And they're analyzing data on such a granular level to look at, again, infection rates, ER visits post-surgery, more conservative treatment options versus surgical options, and getting into provider subspecialties and looking at the data at such a granular level to then determine who these high-performing providers are. So when you kind of marry the two together, savings ultimately become a byproduct of that marriage, in addition to driving more efficient healthcare and better outcomes for members.
And what I find very interesting about this is there's many different paths and ways to do this. You're seeing different types of vendors out there. You're seeing some that they're focusing on one hospital network. This is or a couple of hospital networks, key hospital networks within regions. You're seeing other players that are focusing on, we don't care which hospital you go to, we want the top 25% of any hospital. And we want to make sure, we think even if you're the best hospital, the worst hospital, the top doctors in the worst hospital are going to be better than the lower doctors in the best hospital. So you're seeing both of those things combined, and you're giving people the option based on the different vendors of which strategy they want to take, which I find very interesting. We've seen these, I'm going to call them fads, even though it's not really a fad because this is more of a data-driven fad. But we've seen these things change in the past beforehand. We've seen the micro networks. We've seen a lot of different things that we thought was going to be the next big thing in health insurance. This is probably the newest one. I'll start off with you, John. Is this shift sustainable, or is this just an early adopted territory? How ready are employers and employees for these type of forced decisions where they can see any doctor they want, but they're going to pay less money if they see the doctor we want them to see.
Yeah, as we're presenting these different solutions, or in some cases, carrier-driven options within their broad offering of plan designs, there's a lot of interest around this. Going back to a statement I made earlier, which is, we adopted high deductible health plans and then said to members, hey, shop for care and you'll save money. Well, the problem is they didn't have the ability to truly shop for care. We don't call providers and say, hey, what are you charging for a knee scope, or an MRI? We're not prone to do that. We may do that shopping for a TV or a car, but not when it comes to our own healthcare. And then the other thing that we lacked, even if we could know pricing, it's, well, how good is that person? Am I going to get a good, healthy outcome as a result of working with them? So arming them with this information, there's a lot of interest around that. And I think we're seeing that because all of the major carriers, whether it's the Blues or, any of the other ones, Cigna and United, are all offering products or plan options that empower members. And we're seeing it grow year over year.
Eric, Paige, anything else? Why do you think this is sustainable? Eric, you go for it next.
Yeah, I mean, I think the technology's come a long way, right? I mean, 15 years ago, we didn't have the search engines, we didn't have really the data to support, quality technology to help someone actually be a consumer. And I think, John said it well. We introduced consumer-driven health plans without the tools to actually be a consumer. And I still think we're a long way away from, having the tools in the toolbox in the industry to actually be a good steward of your own health plan and what you're spending on it. But there's I would say, some big steps in the right direction. All of the carriers have some pretty unique tools out there these days to help support these types of plans. So I think that's encouraging. And I think, ultimately, I don't see these going away. To me, this is really a trend that's only going to continue in that direction.
It's interesting. You talk about the technology. We've seen like the Good RX from the pharmacy side. I guess this is
Exactly.
almost like the equivalent of the Good RX for the medical side. Good Medical. We could trademark that name afterwards. But Paige, where do you see this going? Is this sustainable in your opinion?
I believe so. I mean, I would echo, what John and Eric just shared. I think we're still in the early adoption phase, but we're continuing to see, obviously, just a lot more access to data and technology. So that's evolved. But I think it's also supported by the carriers want to play in this space, and they're continuing to evolve in their product offerings as well as, independent kind of vendors and point solutions. So we're seeing that evolution. We're still in the early phase. I think there's a lot of interest amongst clients. Some want to continue to see how this plays out, but I think it's definitely the direction that we will see a lot of health plan designs going in the next probably 3 to 5 years.
Thank you all. That was very informative on that topic. We're going to go ahead to topic number 2 right now, J-code drugs and the benefits that go along with those. So, John, we'll start off with you. Can you explain to us what J-code drugs are, how they're billed, and are they medical, are they pharmacy? For the average consumer of insurance who doesn't know what these are, can you explain them to the layman terms?
Sure. Yeah, J-code drugs are drug therapies that are filled and billed through the medical portion of your plan. They typically mean That typically means that they are administered by a healthcare practitioner, either in a hospital setting, an infusion center, or an infusion nurse in a home setting. So these are very expensive therapies, generally treating people with pretty significant health issues. And the growth is largely tied to just the evolution of better treatments coming out for various healthcare conditions.
So why has this become such a major problem for employers? What's driving the cost? What's accelerating the cost on these prescriptions?
Yeah, the number one cost driver in America right now as a category is cancer. So if you think of cancer treatment, you're thinking of chemotherapy and things along those lines. So that is a big driver in cost. And then also when you see different drugs being advertised on TV, you see or hear of a Stelara, or you hear about people with Crohn's or colitis, rheumatoid arthritis. These are typical conditions that are either managed, the patient is managed either through an injection or an infusion therapy. Someone who has progressed to a higher disease state within those categories would then move to an infusion therapy, and that would become J-code. Interestingly, that same drug injected at a provider's office may fall under the pharmacy side of the plan.
So how do members navigate what's the difference between the pharmacy, the medical? Does it matter? What's the nuances? There's one cheaper. Does site of care matter, or just trust my doctor where they want to give me treatment? John, continue on that one.
Yeah. It really comes down to what the treating physician feels is appropriate care for that patient. The patient really doesn't have a say in it. And generally speaking, if they're prescribed a J-code drug and infusion therapy, that's someone who's managing a pretty serious condition, not a condition that could be managed otherwise appropriately.
So, Paige, I'll give you this one. Many call J-code drugs the biggest hidden cost drivers. Why are they so hard to measure or manage, especially fully insured employers?
Great question, Harrison. So, for a fully insured employer, they probably are getting little to no visibility into, their J-code spend in terms of their overall medical spend. They might see high cost claimants and maybe some, condition information and perhaps total claims, but it is likely quite difficult for them to understand what portion of those claims are actually coming from J-code drugs. And we're starting to see that plan sponsors might have anywhere around 10 to 15% of their medical claim spend could be coming from J-code drugs. These numbers continue to increase year after year, so it is hard to have that visibility unless you're self-insured. And these drugs, as John mentioned too, sometimes they're being used earlier in disease progression and for longer periods of time. Sometimes other times members transition to them later on. But there's not always a lot of competition for these drugs in the marketplace. So the costs are high and provider markups can be upwards of 400% sometimes on these drugs. So you've got the cost of drug and you also have where the drug is administered, as John was saying. So it's going to make a big difference in terms of your claim spend if a drug is administered in a hospital setting versus in home.
So, Eric, this is another reason why we're seeing more and more employers go to self-insure so they could get this data stuff like that. What are you seeing in your market? Are you seeing more employers look towards a self-insured market? Because as Paige mentioned, if you're fully insured, they're driving up your costs, but there's very little you can do about that. Are you seeing this be a driver for self-insured, and what other drivers are you seeing to affect these?
Yeah, I mean, I think, in general, I think rightfully so, employers in this market are just fed up with costs continuing to go up. And they're asking the question of, well, what can we do? I can't continue to sustain a 10, 15, 20% renewal on a $2, $3, $5 million spend, right? So the questions are, what do we do about it? J codes are a big part of the challenge. I hate to say problem because I think that's a negative connotation. I mean, some of these drugs are unbelievable. But I always say pharmacy in our industry is the double-edged sword, right? They are curing conditions and helping people with very severe illness successfully manage those conditions, unlike we've ever seen before. But the ticket price on these medications is unbelievably high. So as an employer, the question is how do we sustain this? And I think self-insurance, to your question, what does it give me as an employer? It gives me more options. Fully insured models by design are kind of, they're set up, the solutions embedded are all sort of, you don't have as many options as far as what you can and can't do. In a self-insured model, you've got options to kind of plug in what we think makes sense based on my unique cost drivers. And J codes being one of those drivers. I think Paige brought up a really good point, which is, the site of care, you can literally see a 200 to 300% variance in cost from an inpatient setting to an in-home setting. Why is that? And there's a lot of answers to the why behind that. But the point is, I think steerage is a successful cost mitigator. All of that being said, I think what's important in any of this is that, uh, these are medications that are treating an extremely scary condition, cancer, immunotherapy. So we need to make sure we're giving employees options. And some people may never want to, transition to a different site of care. They may never have an appetite for in-home, but for a lot of people, those are preferred, right? So giving folks options, I think, is the key to any of this. And ultimately, I think as a self-insured employer, you have more flexibility to deploy some of these things.
It's interesting, the evolution. We've all been doing this for a very long time. I've worked with you guys for 10 plus years at this point, and many of you have been doing this even longer. You saw it was go in network versus out of network, and that'll save you money. It was a couple of years ago was the pop-ups of urgent care. Don't go to the emergency room, go to the urgent care. And now we're seeing the J code revolution, let's call it, where we're focusing on where these are coming. And it's just the next evolution in this ever-changing world of health insurance. John, I know you have a lot of clients that have done some really interesting things to save money on J codes. Can you give us some true case studies or example or share some information about how you've helped your clients control their costs once they obviously are self-insured, and how the other people can take advantage in this evolution of the changes in health insurance?
Yeah, Harrison, thank you. As Eric had mentioned, when you're self-funded, you have a lot more flexibility. So I'm going to use one client example. They're self-funded. They have about 6,000 or 7,000 employees, somewhere in that range. So figure 10 to 12,000 members on their health plan. Again, self-funded. We saw an escalation in J-code spend, and interestingly, it was around two large claimants in particular whose claims went from about $20,000 a month to over $100,000 a month each. We had talked to the client previously, about a year prior, on J-code drug management and potentially carving it out to a vendor outside of their health plan. They were not keen on the idea because they felt it was a little disruptive. When we showed them that these two claimants were going to cost them closer to $2 million in the coming year, they were more receptive to a carve-out. So we looked into a carve-out scenario. We were able to move these people, the coverage, and the savings year over year on this group was $1.4 million. So what we did is we were able to look at all the J-code drugs that were prescribed and used for treatment in the prior year. We did an average cost per claimant. We looked at the actual drugs, and then we tied it to what the new pay scale was, basically through this carved out solution. And the cost reduced around 37% from leaving it bundled with a big major four carrier to carving it out to a specialty vendor who specializes in J-code drug management.
And John, these were the exact same drugs. It wasn't the discount brand. It was the exact same drugs, just administered differently. From the member standpoint, in these cases you've seen, was it a positive member experience? Did they have a negative member experience?
Yeah, it's a great question. We actually the client received very little feedback. They did receive very favorable feedback from one of the two most expensive members, because one of the things that this third-party vendor did was encourage them to have this treatment provided at home in a home setting with a IV infusion nurse. And they just found that to be a much more comfortable setting. And the cost went down about 60% for that one member alone. And otherwise, there was really very little feedback. The client did a good job of communicating what their intention was. And the hope was to ensure that all members would receive the care they need, would receive the medication they need. There were no roadblocks to getting the care, but it was going to give them options for site of care and also just lower the cost in general. We also were able to remove the member cost share. So there was a copay associated with that IV treatment, and we were able to eliminate that because of the cost savings that the plan achieved.
So that's amazing. We're able to do it at home and once again, anybody who's gone through a family member suffering from cancer, unfortunately, I had that. You know that sometimes, I'm not going to say the hardest, but sometimes it hits the spouse or the people, the caretakers, just as hard. You have to take off time from work to help take them to the doctor for their infusions. You're missing time. You have to get a babysitter. It's the old Aflac pitch, like you need these products because it's the out-of-pocket expenses that add up. What I'm hearing in a situation like this, and Paige, Eric, I'll let you guys comment on your experience with these as well. What I'm hearing from your story, John, is it's not just saving the organization money. The member has no co-payments on it, so no cost share on it, so it's saving them money, but it's also providing a little relief to the other members of the family who might not need to take as much time off from work. Or even if they're taking time to be with them, maybe they don't need a babysitter to take care of the kids, or they can cook dinner, or all those other aspects that we've all talked about. Eric, I'll go to you next. Have you seen different experiences and cases, stuff like that, a similar concept?
Yeah, I mean, to not be redundant with John, I think I'll focus on the member experience a little bit more. I mean, I think what's key in all of this is that we're giving the member the choice, right? Typically, the way that this is structured is if I want to go to sort of the recommended path that maybe my provider recommends, who's managing my infusion therapy, maybe that is in a hospital setting, which we all know is more expensive. But we can structure the plan in a way that says, okay, if I, as the member, choose to redirect my care to a different setting, to John's example, perhaps at home, there's some incentive for me to do that. Maybe it's a reduced cost share, maybe my copay is waived completely. So I think in my mind, again, we're talking about people that are dealing with an extremely stressful life event. So we need to be careful about, kind of forcing the hand. I think the beauty of the way that most of the time we arrange this is that you're giving people choice. And if someone wants to do it the more traditional path, they can continue to do that. They may have a higher cost share, but if I'm willing to be flexible and maybe open to something that's slightly different, there will be a financial incentive to do that by way or by, via the plan design. And that's ultimately how we're going to create meaningful engagement in this type of program.
And Paige, continuing on that notion, you're giving them the choice. How do you help them make the right decisions? How do you help them from a financial standpoint? What are the strategies you're seeing to help people decide, do I want in the hospital, do I want at home, or educate them on these options?
So I think it's interesting. I think it circles back around to where you started this part of the discussion, Harrison, which is there's a lot of trust when you walk into your provider's office in terms of perhaps what they're recommending and where they're going for care. And if they need an infusion, okay, we can do it in the clinic, we can send you to the hospital. But in the solutions kind of that we're discussing here that Eric and John have touched on, there's a lot of hand holding in these partnerships with J Code vendor solutions where they are doing that deep kind of member education to let them know what their options are. And there are going to be times where it's just not clinically appropriate to move them out of a hospital setting, perhaps. But to Eric and John's point, educating them, letting them know that they have choice. I think a lot of people would choose a more comfortable in-home setting, and like you said, take the pressure off the caregivers. And some of the partners that we have worked with, over the recent years, they do a great job helping take care of that kind of member education and take that responsibility off the employer. So it's not the HR department that's having to kind of necessarily, do that education, but a great partner can really walk them through what their options are from a clinical standpoint.
So we're seeing a common trend, once again, these first two topics, the navigation, the J-code drugs, it's providing options to employees, it's providing solutions to employees, it's educating and incentivizing them, but not necessarily forcing their hands. And I think that's a great trend we're seeing moving forward. And I love how that's the evolution of healthcare, where it's not just small networks, large networks, micro networks, take it here, move it there. It's data. And I think AI has a lot to do with this because we're now able to go through so much more data and sort so much more data in such a fast time that there's so much at the fingertips of the employers, the healthcare carriers, everything like that. We're about halfway through at this point. If anybody has any questions they want to put in the chat, I'll pause for about 10 seconds, let our speakers grab their breath for a second. But if anybody has any questions, feel free to put those in the chat. I will read them. If not, we'll move on to the third topic. Doesn't surprise me there aren't that many questions. You guys have done a great job explaining these and giving the full story over there. So diving into our third topic, which is probably all over the news right now. I don't think any conversation has not consisted of a GLP-1. John, you mentioned the prescriptions you hear in the commercials. I mean, whose kid hasn't walked around singing the Ozempic song and humming that tune under their breath? But talk about the GLP-1s. I don't think I have been through one open enrollment or benefits conversation the last year and a half without this coming up. John, not to pick on you, but based on what you've seen over the years, how is GLP-1 market how the GLP-1 market affecting consumer health insurance plans?
Yeah, they're having a tremendous financial impact on health plans. They're also having a tremendous favorable impact on patients. So, and I think that GLP-1s, we at times, because it's so much in the media, we tend to think weight loss. And yes, that is a significant component, but that's the one that is more voluntary from an employer coverage standpoint. GLP-1s for diabetes and other conditions, cardiac and now several others coming down the line, are really where these drugs are doing great work. To talk about financial impact, the frontline drug for diabetes, type 2 diabetes, for 30 years was metformin. Metformin costs about $40 a month per prescription. The GLP-1, which is a superior drug today for type 2 diabetes, is around $1,400 to an employer. So that is a huge price variance. It's a more effective drug, but also we're finding people are hopping from metformin, even though they are managed pretty capably on metformin, are hopping to the GLP-1s for diabetes.
So, John, you mentioned for the diabetes standpoint, Eric, for the weight loss, these Zepbounds, Wegovy's, not the Manjaros, where are you seeing that in the marketplace? What impact are you seeing those have on your clients, Eric?
Yeah, I mean, I'll caveat. I am not a clinician, so my opinion from a clinical perspective should be criticized no matter what I say. But I can tell you, I mean, from my personal opinion, I mean, clearly they work, right? And people are having a tremendous amount of success losing weight, tremendous amount of success managing chronic conditions such as diabetes, cardiovascular disease, which is all amazing. I think the weight loss conversation is interesting, right? And I think we're still a little, we're definitely early in this conversation. So I would agree with your sentiment, Harrison. I don't know that I've really had any client discussions, let alone probably like, Thanksgiving or, family discussions where GLP-1s just don't randomly come up, which is an interesting, time to be living in. But, um, the price point is changing so quickly, right? So if you look at it through the lens of an employer and you're asking yourself the question of, if I cover this medication, we know it's going to cost me, anywhere from call it 8 to 12, $13,000 a year per member that ends up using the med. Am I going to get a proportionate or greater than reduction in cost for those members? I think is the question that most people are asking. And I think it's a little bit too early to tell. Some of the early studies, when the price point was higher, were not showing an ROI for the weight loss category of of the GLP-1s. The price point is coming down. We all see, GoodRx, some of the Eli Lilly direct price points, Trump RX, so I think the arithmetic on ROI is changing pretty quickly here. But I think, as any employer should be asking, it's, well, what are my options? Can I do this, within the guardrails of my health plan? And is it good or bad for the long-term, financial stability of my plan. And I think my long-winded, maybe non-answer in all of that is, too early to tell. But I think it's worth the conversation. And it's certainly, we're getting more and more data every day to kind of conduct that cost-benefit analysis.
It's funny, probably about a year ago, I had a conversation with somebody here in our office, and we were talking about how this is the first time we were seeing HR win over finance. When companies are deciding whether or not to offer the GLP-1s, we're seeing HR win that conversation over the finance because the finance is saying, I'm not seeing the ROI. But the HR is saying, yeah, but from a cultural standpoint, it's working. People are losing weight. People are more active at work. People are not having as many sick days, so on and so forth. It's the invisible ROI. We're going to offer it anyway. And I'm seeing that change. And a lot of why I'm seeing that change is there are other options out there. Paige, I'll give this one to you because there's a lot of confusion out there. You have no clue how many clients have come up to me and says, well, Trump RX, now the costs are going to be cheaper on these prescriptions or best pricing. Now we can get them for a cheaper price. It's going to affect my medical plan, correct? And the answer is no, not really, because those aren't medical. Can you give a little bit of these direct-to-consumer models, these Trump RXs, and what that means to a health insurance plan or what that doesn't mean to a health insurance plan for the ones who might be confused by that?
Sure. I think actually John will probably want to take the direct to consumer question, but I just would like to kind of add to what John and Eric have shared in terms of what we're seeing on the client side is that I think we're at an interesting juncture where the ROI right now can be negative on GLP-1s for weight loss because it's just this really high cost, right? It might be over $1,000 a month per member, as Eric was saying. But if you look at it over the medium to kind of long-term horizon, there could be some serious ROI there with, reducing type 2 diabetes and blood pressure, improvement and so on and so forth. So I think we're at the juncture we're kind of at right now, apart from clients being frustrated with some of the direct-to-consumer pricing, is that there needs to be more guardrails in place. So, I think the floodgates were opened initially with a lot of plans and access to these drugs with perhaps maybe not stringent enough criteria. And now we're seeing a little bit of kind of tapering there with stricter criteria or what other lifestyle modifications are needed to ensure long-term success, beyond the access to the GLP-1. So those are kind of the topics I'm discussing with clients right now. But John, I'll let you jump in on the Trump RX and direct to consumer options.
Yeah, as Paige knows, this is a hobby of mine. I spend a lot of evenings just tracking the GLP-1 market. It's really it's
It's like the
pretty
stock market for
interesting.
you, John, no?
That's right. So I think where a lot of my clients and other employers that I talk to, and when I talk to my fellow consultants and account teams here, and even with some of my competitors, there's a tremendous amount of frustration because employers are charged one amount, as Eric had mentioned, on the low end, seven could be as high as $14,000 a year for them to provide that drug. So that equates to $600 to $1,100 a month for that prescription. And yet consumers can go directly through GoodRx, Trump RX on a consumer model and get it for one half, in some cases, one third the price. So employees often think that the employer gets that same pricing when in fact they don't. So I think that creates some level of frustration. And then there's a tremendous frustration on why, as an employer, am I forced to pay significantly more? I think a lot of employers, if they were granted the option of the direct-to-consumer pricing of, $250 to $449 or $499, depending on the drug, that they would likely be more inclined to cover the drug. Luckily, there are some new strategies that are coming down the road that will enable employers through third-party vendor relationships to leverage the direct-to-consumer pricing. And we're starting to put together some studies on that and options that employers will have.
So, Eric, are you seeing any of your clients take advantage, or are you seeing them now say, hey, we're not offering them anymore because you can't get them direct to consumer? What are you seeing in the marketplace from an employer standpoint? Has these new direct-to-consumer pricings changed the marketplace, and how are they getting creative to manage this?
Yeah, I would say in the Florida market, we didn't have a lot of early adoption 2, 3 years ago in the weight loss coverage of GLP-1s. It was definitely more of the exception. For the ones that did jump into that world, I think you are seeing, to Paige's point, more guardrails put in place, right? I think what's important, no matter what, whether you're taking it for, diabetes therapy or weight loss, adherence is important. You see a lot of people dropping off of GLP-1s within the first year. I think it's something like 75% of people that take weight loss are no longer taking them 12 months later, which is kind of shocking. So forcing adherence as kind of a gatekeeping mechanism, I think, has become more and more common for the employers that are covering it for weight loss. And then to answer your question a little bit more directly, with the evolution of these direct-to-consumer price points, you are seeing more and more employers either peel out of it completely and say, "Look, employee, you can now buy this same medication at on GoodRx for $250 a month." We're no longer supporting that element of the plan. Or, there are some creative solutions out there that are actually very new, where essentially employers are funding some form of an HRA to potentially purchase those medications direct to consumer as well, where it's sort of quasi-sponsored by the health plan from just a dollars perspective, but the plan itself is not covering it. It's an exclusion, which then allows the member to, qualify for some of those direct to consumer options.
So we're seeing a lot of changes here. We all know these conversations are happening all over the place. I know none of us have a crystal ball and none of us know what's going to happen in the future. But looking ahead to 2027 renewals, we're starting those conversations obviously now with the broad access to these new prescriptions. Paige, what are you seeing clients start questioning? How are you advising your clients to manage this moving forward, or guiding them to manage it moving forward?
From a GLP-1 perspective, or
Correct.
just in terms
Yes.
of, I think, well, we're seeing, we've seen a lot of I guess I would say reluctancy or hesitation in this space. Initially it was very exciting, and if there was access to these drugs, just let's say on the fully insured side, if a carrier included it in the formulary, that was great. And then obviously we've seen the carriers pull back over the years, and then now we're seeing self-funded clients that may have covered it tend to pull back too, just because, as Eric and John were saying, there's been so much volatility in the pricing, the direct-to-consumer pricing. We're kind of waiting for that to stabilize, and I think once it's a little bit more of a level playing field, I think we're probably going to see more of an openness to perhaps cover these, more broadly. But right now, just I employers are trying to get their arms around cost control, and it's a easy lever to pull back on if that is an area where there have just kind of been runaway costs. So we are seeing shifts definitely in that space, as well as, again, kind of looking at J code carve outs and things of that nature on the medical plan side.
Yeah, I think it's going back to what Eric said, where a lot of people will take it for a year, and for whatever reason, whether it's side effects, whether it's not wanting to take a shot, or just they lost the weight and they don't want to do it anymore, they're getting off of it. And what we're seeing is they're putting the weight back on. These aren't changing people's behaviors. They're either I don't want to use the word temporary fix, but it's a superficial fix to a lot of the underlying problems. And we're seeing people go back. So I guess if there's a way to get them in certain people's hands to do the right things, I think that's what we're seeing a lot. The guardrails be set up. But I think something else I heard from you, and I'll give this the last to John for the last question on this is another reason we're seeing employers go self-insured, because in a fully insured marketplace, you don't have options. John, are you seeing, not specifically GLP-1s, but obviously this is coming to the conversation where we're seeing more and more employers explore the self-insured marketplace?
Yeah, absolutely. I think all of the strategies that we talked about today and the cost drivers as well as others that we didn't even get into on the, broader on the pharmacy side and other pieces of medical management. There's a lot more interest in self-funding. And of course, as costs in general continue to rise, it used to be, a 100 life group had $1 million of premium. Now a 100 life group can have several $1 million of premium. And now all of a sudden, self-funding, when you're saving 3, 8, 10%, self-funding alone isn't a magic bullet. But if you can trim out premium taxes and margin and a few other things, all of a sudden you take 8% off of that $3 million of spend. That's $250,000. That gives the CFO a little more comfort. And then you add in the fact that you have more flexibility around plan management, more creativity. I think it's just opens the opportunities. With that said, it's still not the right fit for every employer. So the employer has to know what their risk tolerance is and what they're truly looking to get from a control out of their health plan.
So once again, we're getting close to time here. I want to wrap it up with one question. This came about because of trends affecting the 2027 renewal. And we all know that it takes a long time to start preparing for the renewals. I'm sure all of us have probably through the strategic planning meetings right now, getting ready for the mid-year reviews. We know each organization is a snowflake and no two are alike. But I'm going to give you a broad question. Eric, I'll start with you. What's one question each one of the plan managers needs to be asking prior to the 2027 renewal? What's one thing they need to be exploring and looking at or making decisions on early on?
Well, I'll start with I'm not getting any back alley kidney transplants, Harrison. So we'll start there. But no, I think I'm a data guy, so I think what are my cost drivers is the question that I'm asking. Do we have the data that we can mine to understand out of our multi-million-dollar spend, what are the top 2 or 3 categories that are driving our underlying claims? And then ultimately, I'm asking, what can I do about it? And some of the things that are driving claims we can't prevent, right? I mean, cancer will always be around. There's certain things we can't prevent. So the question is, for the things that I do have control over, what are the levers that I can pull? And then I think, ultimately the answers to that will either dictate whether or not self-insurance is the right path or fully. I mean, there's a lot of groups where fully insured is fine. And there are a lot of different levers we can pull within a fully insured ecosystem to help control underlying cost drivers. But I think that those are the questions that I'm asking is what's driving cost and ultimately what can I do? What levers can I pull to mitigate some of those cost drivers?
Paige, same question.
Yeah, you're going to hear kind of a similar theme from me, but I think back to the just funding arrangement, you should be asking that question every year. Am I still in the right funding arrangement? So that's, something your consultant should be helping you look at each year. But beyond that, what are, to Eric's points, kind of the top 1 or 2 levers that I should be looking to pull that will have the most positive impact on my trend, but still aligns to my organizational values and culture. And then what happens if I don't pull those levers? I think, there's a lot of groups that, and, clients that like to look at options, but then maybe based on kind of the culture decide to, wait and see. But it's also, I think, our job as consultants to help educate them. Okay, what's going to happen if you don't make those changes today? In a couple more years, that trend is only going to continue to compound and so on and so forth. So asking those questions, I think, is important each year.
And John.
Yeah, I think that we ask multiple questions, and Paige and Eric, I align exactly with what they said. And I think the other question that I ask clients in ongoing planning meetings, but I also ask this of new potential clients when I meet with them, is what level of disruption are you comfortable considering for your population? And the reason I say that is if no level of disruption is the comfort level you have, then I think you have to resign yourself to the fact that it's the old school method of negotiating the best discounts or prices and just run with it that way. Disruption doesn't have to be a bad thing. we talked about the J code strategies are not, that's not a bad level of disruption, but it is disruption. Your employees are going to now maybe have a choice, and maybe it's going to impact their cost. Giving them access to tools that allow them to shop for the top providers and top facilities for different procedures is a level of disruption that a lot of people don't do today. To me, it's a positive level of disruption, but it's still a different way that they're going to access healthcare. So I think that that's a question that all employers should be asking themselves. What is a comfortable level of disruption for me to change the trend that I've been seeing in my healthcare over the last 2, 3, 5 years?
It's funny you say that because one of the jokes it's a joke, but it's not a joke. One of the things I always tell my clients is, you tell me a number you want me to hit, I'll tell you how to hit it, and then you tell me if you're comfortable hitting the number that way. And usually we meet somewhere in the middle. Like, you want to see a flat renewal, I can show you the flat renewal. You just have to see if you can go to sleep and sleep through the night. I'm going to give you guys a little different question, one that I've been asking my clients a lot. And a lot of what we're talking about falls on the responsibility of the consumers and the actual members and employees. And this goes into John's disruption a little bit, but how educated are my employees? How are they at being consumers of health insurance? And how can I better educate them on what's going on in the marketplace? Because I think that's something we need to look at more so now, because all three of these topics we've been talking about, whether it was the navigation, whether it's the J code drugs, whether it's the GLP-1s, these are all amazing things which has both the positive and the negatives, but are disruptors, as John mentioned. And if my employees are better consumers of health insurance and they understand what I'm trying to accomplish, then they're going to be on board with this, and it's going to be a lot easier to implement these things. So I think asking myself, or asking what's my communication strategy to implement these changes, is going to be very key. So I'll leave with that, but I want to thank the three of you for this very informative session. Thank you, John. Thank you, Paige. Thank you, Eric. Thank you, everybody who attended this session. Hopefully we left you with something to chew on. And Brianna, you want to tell everybody how they can get their CE credits?
Yeah, for sure. So we're going to send you an email within the next day or two with the recording link and the credits, and then you should be able to apply those. I'm going to put a little survey in the chat if you wouldn't mind giving some feedback there. And that survey will also be in the email as well if you don't have time to do it right now. Thank you guys so much for attending. If you have any questions, you can email csg.events@corpsin.com or any of the four on the screen if you have their contact. I'm sure they'd be happy to help as well.